Hi, everyone. We're just going to give it a minute here for everyone to get in the room, and then we will get started. All right, let's see. Okay, looks like it's slowing down, people coming in the room, so we can get started. Hi, my name is Kristen Bellamy. I am the physician relations specialist for Rothman Orthopaedics. I am here with Dr. Selene Parekh, and he's going to speak to us tonight about ankle replacement. Just a little bit of housekeeping. We will be doing a Q&A at the end, so if you have any questions, you should see a little block down there for the chat. You can put your questions in the chat and we will address them at the end. We do ask that you keep it to a general question, not specific to your own care. If you do have a really specific question, we are happy to, get you set up with an appointment. You can just send me an email. Everybody here should have my email and my phone number, so you can just reach out to me and we can get you set up with an appointment. I'm going to do a quick intro and then Dr. Parekh will get started. Dr. Parekh is a board certified, fellowship trained orthopedic surgeon who specializes in the treatment and conditions of the foot and ankle. He is known for utilizing state of the art implants and techniques that he's designed and developed to provide better support and offer limb salvage. Dr. Parekh also focuses on minimally invasive surgery and is a pioneer in the use of 3D printing techniques, total ankle replacements, and the treatment of foot and ankle conditions in athletes. He sees patients in our Bensalem, Pennsylvania office, our Newtown, PA office, as well as in Princeton, New Jersey. And with that, I will turn it over to you, Dr. Parekh.
Awesome. Well, thanks, Kristen, and thanks everybody for tuning in. I know we are recording this, so don't feel like the need to take any notes or jot anything down. I believe Kristen will be sending you guys a link later on with the recording. So feel free to just sit back and listen, and as you have questions, put them out in the Q&A. As Kristen said, my name is Selene Parekh. I'm one of the foot and ankle physicians here at Rothman, one of the surgeons from an orthopedic perspective. And today we're talking about your ankle being reimagined, arthritis relief through personalized joint replacement. Not twice. I don't know why the title slide has it twice. Um, Ankle arthritis is an epidemic. And I mean that not that it's way out of control, but it's actually increasing in severity, more often because of post-traumatic issues, right? Most of the ankle arthritis that we see is post-traumatic due to ligament or bony injuries. You all have probably suffered an ankle sprain at some point in your life. There's more and more research being shown that repetitive ankle sprains or even one bad ankle sprain can fundamentally change the mechanics of an ankle and lead to ankle arthritis. We're also seeing a younger population being affected by ankle arthritis, unlike our hip and knee arthritis patients who tend to be much older. We can see ankle arthritic patients much more often from their young years, even from the 20 somethings, all the way to 60, 70, 80-year-olds and beyond. The impact on quality of life is quite severe, and there's some research looking at how badly does ankle arthritis bother a patient. And if you look at self-reported patient outcomes and patient pain scores, there's some suggestion that ankle arthritis is equal to or exceeds the disability of end-stage kidney disease, congestive heart failure, or cervical pain from your nerve being pinched on from the back of your neck. So you may think, oh, it's just my little ankle, but it can actually have severe impact on your quality of life. And most of you, if you have ankle arthritis or know anybody with it, know that this is quite the case. So it can cause significant pain, loss of motion, limitations in activities, usually some of the more intense activities, but as it progresses, it can affect even your daily life activities, just simply getting out of bed and walking. And so the treatment selection is critical for restoring quality of life. Now, the ankle is different than your hip, your knee, your shoulder. First of all, the anatomy is much more complicated. And so I have a picture on that left-hand side, lower left-hand side, the cartoon showing a lot of different bones are interacting with one another right at the ankle. So that's number one. Number two, the mechanics are much different, right? Your whole body weight is coming down to these two tiny little joints on either side of your body, taking all of the load of what you're doing from impact to non-impact activities. The cartilage of the ankle joint is different than the cartilage of other joints in the body. It is thinner, it's metabolically different, and it really does not have the ability to restore itself if there's any kind of trauma or any issues that occur with it. Additionally, it is biomechanically sensitive, meaning that if the mechanics are off in the ankle, that can lead to ankle arthritis. And so when you look at these two pictures here, one at the top and one at the bottom, you'll see the top is a normal ankle joint. The cartilage is nice and smooth, almost like the cue ball when in pool. And in the bottom, you can actually see a patient who's actually developed severe arthritis where the white has gone away. That's your cartilage. And what you're looking at is bare bone. And so this is severe arthritis where that cartilage is worn out. Now, the cause of arthritis in the ankle can be post-traumatic, right? So post-traumatic can be an ankle sprain, like you see here. Steph Curry has this really bad ankle sprain, or it can be primary, meaning it's not due to trauma. Now, when we look at the ankle, most of the ankle arthritis we see is post-traumatic. It can be from a broken bone in and around the ankle. It can be from an ankle sprain that's been severe, causing instability. It can be from lower extremity malalignment. All right, so think about the alignment of your car. If it's nice and aligned, you don't wear those tires out as fast. But if your alignment's off, you wear out your tires faster. It's the same thing with the ankle. Now, this is different than primary arthritis, which tends to be the minority of cases we see for the ankle. And usually, primary arthritis you will see in multiple joints in the body, but in the ankle, you'll see it primarily in both ankles. And we don't oftentimes see it in both ankles from a primary setting. We can see it post-traumatically, but not primary. So I want to quickly touch upon conservative management, surgical decision making, the evolution of total ankles, personalization, and then outcomes that you can expect. And then we'll talk about personalization. So when do you consider conservative treatment? Well, for us, we always will try to consider surgical conservative treatment first, right? We want to talk to the patient. We want to understand what your difficulties are, what your challenges are, how you're suffering from the ankle arthritis. And then we want to focus on pain reduction. And I look at this as a stepwise approach. We want to slowly bring you along the path and raise your invasiveness higher as things get worse and worse and worse. And so we want to utilize the low-lying conservative options first, and then go to more of the invasive options. So these non-surgical treatment options can include anti-inflammatories. It can include steroid injections. And typically, we don't recommend more than 3 steroid injections into each ankle, no more than 3 in your lifetime. At that point, there is some concern that you can cause bone death. So unlike other joints in the body, we really don't want more than 3 steroid injections into the ankle. And then also regenerative options, things like stem cells or PRP. They can be used for early to mid-stage arthritis. We'll also look at mechanical interventions like an orthotic or an ankle brace, like you see in the upper left-hand side, that white brace, that's called a molded ankle-foot orthosis. Technology is allowing us to potentially have patients use some really cool novel technology. In the center here, you're seeing what's called an exoskeleton. It's something that you can wear. It takes a lot of pressure off your lower extremity and allows you to move much more easily. It's really meant more for high impact or long duration employees who are working on their legs all the time and they just need some assistance. But you can see how the same technology that's used in the workplace can be used for patients who have arthritis in their lower extremity and help take some of the pressure off their ankle. There's also some novel braces, like the lower right-hand side picture. This is a brace coming out of Seattle that can be customized and can really help take some of the pressure off patients who have ankle arthritis. We can also do shoe modifications to kind of give you a little bit of a rocker, something that you lose as your ankle arthritis gets worse and worse. Physical therapy is very important early on, from stretching and mobilization to the joint to strengthening the muscles around the joint and the tendons around the joint. And really, we're trying to manage your symptoms through activity modification. You can use ice and heat therapy, and then patients will self-regulate to what they feel is most comfortable. Now, with conservative care, the clinical evidence shows we will give you initial relief typically, but what happens here is as that arthritis gets worse and worse and worse, you get diminishing returns from these non-surgical treatments. And then you start thinking about surgical options. And when you think about surgery for the ankle arthritis, there's really two big buckets. It's ankle replacement and ankle fusion. And there's a little bit of a difference. Now, the traditional gold standard has been ankle fusions. But in the last 20 years, this has changed dramatically with ankle arthritis, allowing patients to have motion. Now, here's a patient who had an ankle fusion. It's not one of my patients. This is a video online that I was able to pull off. And you could see that even with him walking, it's not exactly a normal walking pattern. There is some a little hitch in his gait, in his walking. Now, ankle fusions do give you 90% pain relief or better. They're reliable. And if they do well, you won't need anything more done on your ankle. However, everybody who has an ankle fusion has a limp. For some people, it's not noticeable at all. Others, it is noticeable where you individually would end up. No way to really predict. And because that joint doesn't move anymore, the energy that used to go through that joint still gets absorbed by your body. So you may notice that there's more pressure and more symptoms of your knee, your hip, your lower back because of this energy being translated up the chain of your leg. And so these are important considerations in the era of now having an option that gives you motion. So total ankle replacement is a true paradigm shift. We are looking to preserve motion. We can give you pain relief, just like an ankle fusion. You get 90% pain relief or better, but functionally, it is more superior than a fusion. And we'll touch upon this a little bit more, but you can be much more normally active in your day-to-day life with an ankle replacement, having that motion that's so important. Now, when we do ankle replacements, we really need to think about patient selection. So we look at the demographics, we may look at your BMI, your activity level, your expectations, your occupational demands, and then we look at clinical factors that are really relevant as well, because this may affect whether or not you are a candidate for an ankle replacement, but will also affect some of the implant choices we may make for you to decide what implant may be best for you. Now, there are certain situations where we really shouldn't be doing an ankle replacement, and these are relative to absolute contraindications. So if you have an active infection in your ankle, not really a candidate for an ankle replacement. If you have severe loss of blood flow to the toes, where you don't have great blood flow at all, then you probably aren't a candidate for most surgeries unless the vascular surgeons can restore that blood flow. There's something called Charcot arthropathy, where the bones in the center of the ankle start falling apart. If you have that, we can't give you an ankle replacement. And then you can have severe deformities like you see in the pictures here, or you can have some medical comorbidities like you see in the picture on the right, where you really shouldn't be a candidate for ankle replacements. And there's an argument to say even an ankle fusion may be very difficult. So these are the things that we consider when we see patients. Now, ankle replacements have been around since the 60s and 70s, but we learned from the early failures. And those early failures actually discouraged people from continuing the offering of total ankle replacement to patients. So in the 60s and 70s, this is one of the first replacements done on the right-hand side. Now, I know most of you guys have never probably seen a hip replacement, but this is just like a hip replacement being turned upside down and being used in the ankle. These types of surgeries did not do very well at all back in the 60s and 70s. And again, the medical community abandoned the procedure because of these issues. These issues were related to the implants not honoring the mechanics of the ankle. They created a lot of bone loss, and then the designs were not really anatomic. So we have kind of come through waves of the first generation being done in the 60s and 70s to the second generation improvements. And depending on how you name these We are in the third, fourth, or fifth generation of these implants. And there is renewed optimism with these new implants because they do honor the mechanics. They do give patients better motion. They do take less bone, so we keep as much bone for the patient as possible. And if you look at along the current state of ankle replacements today, across the globe, there are over 20 implants that are now available. The 10-year survivorship is 91 to 95%, meaning that at 10 years, 91 to 95% of these implants are still doing well. That is the same type of success that we see with hip and knee replacements. So this now is a very real option for patients with ankle arthritis. In the US, here's just a spattering of some of the implants that are available. These modern implant designs can vary from those that are very low bone sacrificing, meaning you don't take much bone at all, to those that need much more bone to secure them. We have what we call primary implants, those that are done for patients who've never had an ankle replacement before, to now revision implants where we can give you more of an implant after that first one fails. We can actually go to the third and fourth generation of revision implants. Now, the way we do this, we approach your ankle either through the front or through the side. There's only one implant on the market that's through the side. The rest are right through the front, which is the most traditional way to do it. And there are constantly material and coating advances occurring in the total ankle space. There is continual research looking at how do you get this to secure better to bone? How do we keep refining and honoring the ankle joint mechanics? How do we get the bone to bond better to the implant? And so all of this is continuing to progress. Our off-the-shelf options is what's really standardly done. Some of these implants offer you a combination of over 600 combinations that we have in the operating room for the one surgery, and we can pick and choose what you need as we're doing the surgery. And so we have that availability of over 600 combinations, but it's not fully custom and it's not fully anatomic, right? These are off-the-shelf options that have a lot of combinations to get you as close as we can make it to custom, but not custom. So why does personalization matter? Well, we know there's differences in people's individual anatomy and biomechanics. And although we are very careful with selecting the patients who need which implants, personalization does allow us to do some really interesting things. The initial way personalization is being done, and really one of the more popular ways, is the pre-operative planning, meaning we get an x-ray and we start understanding what does your anatomy look like. Then we send you to get a standing CT scan. It's not the usual CT scan that you get when you're laying down, but one that is done while you're standing. Now that all can give us information that we as a surgeon will then sit down with the engineer of the company and we will start planning these surgical guides to help us do the surgery to put in the off-the-shelf implant, right? And so we are looking on these CAD drawings that are created to look at your alignment, look at any additional surgical procedures that may need to be done at the time of your implant, whether there's bone cuts that need to be done, whether the ligaments need to be rebuilt, whether the tendons need to be transferred, whether other joints need to be fused. We're getting a deeper understanding of this through these patient-specific guides that are being created. Through the process of making that, we're starting to understand all these things that may be needed to be done. And at the end of the day, we're trying to optimize a bone-sparing technique. We're trying to leave as much bone behind when we do an ankle replacement so that in the case of you needing a second or third or fourth revision, we have a lot of bone to work with. We always got to think about adjacent joints, the joints near the ankle. We want to look at those in the pre-operative time frame when you're in the office being seen. We've also got to think, are there things that need to be done in the operating room to those joints to help set us up for a successful outcome? Because we're at the end of the day, we are trying to prevent early failures and really give you a long-term success. So here's a patient who had one of these, we call them PSI guides, patient-specific guides. And you could see that this is a front incision. These guides can be put onto the joint around a top and bottom of the joint to do the surgeries much more quickly, much more efficiently. But more importantly, a lot of the planning has been done before the operating room has happened. so that we can execute a surgery that's very seamless. Now, this is not 100% needed, but it's certainly a nice to have. And for surgeons who are total ankle replacement surgeons who do high volume, many of them don't use these techniques, but you can use them, and they can help facilitate the surgeries. Now, as a surgeon, we always want to make sure we're incorporating patient preferences. We want to understand what are the outcomes that you want, what is your daily life demands, and really where are you trying to go in your life so that we can see if we can help you get you there through a total ankle replacement. So this is a shared decision-making process. But the pain relief from an ankle replacement is real. Up to 90% pain relief or better. It transforms quality of life. It returns patients to daily activities and even recreational activities. When we look at overall satisfaction from patient scores, 85% of patients or more are satisfied with their implants. 90% or more would choose the ankle replacement again, and 80% or more state that the ankle replacement met their expectation. Remember, this is a joint replacement, meaning it gives you motion. It's not going to be normal motion, meaning the arc of motion you have won't be like your uninjured side, but it's usually better than where you were before the surgery. And most patients get about a 25 to 30-degree arc of motion, which is mostly enough to do most of the things you want to do in your life. It helps to improve gait mechanics, basically getting up and off a chair, getting up and off the toilet, going up and down stairs. We have patients who are skiing, walking, hiking, biking, elliptical, even playing light tennis or even pickleball. We allow them to do that. So it improves their daily activities and their mobility. And so understanding that is very important. We also tell patients we don't really want you running and jumping on these. So if your intent is to get an ankle replacement and then just run and jump, you just need to know that we can't predict how long these would last. The studies are done on patients who are not running and jumping. There are not in the US studies done on patients who are running and jumping at certain levels to understand what does it mean to the outcome of the total ankle. And this concern of running and jumping is for hip replacement, knee replacement, ankle replacement. It's just any artificial joint that's in your lower extremity. We have to understand this. Um, Functionally, total ankle patients do better than ankle fusion patients. When we look at patient-reported outcomes and their functionality, they do better with total ankle replacement. However, it's not without complications. So patients with ankle replacements can have these loosen over time. They can develop fractures, like you're seeing here on the right-hand side of this picture, a fracture that developed or a broken area of the ankle that developed after the implant was in. They can develop loosening where the implant will loosen and then also start sinking into the bone, which is what this left CT shows. They can also develop what's called impingement, where on either side of the implant, your body starts creating so much bone that that new bone is rubbing up against the implant, causing pain. And so we can deal with these things. So here's a patient of mine who had a fusion surgery done, then needed an ankle replacement. So this is what the ankle replacement looks like. And things are going great. I usually see my patients every year for the rest of their life. He had been lost to follow-up, meaning he stopped coming to our office for about 4 years, and then he came back. And what we see here, if you look at this left x-ray here, and I don't know if you can appreciate this, but the half circle implant, that talus implant, has sunken into the bone. That is what's called subsidence. And with that sinking in, now this implant becomes very painful. So in the era prior to 3D printing, we would have had to take this entire thing out and basically lock up or fuse this ankle joint. And that would mean that this patient would lose all motion. But with 3D printing, we can do some really cool novel things. So we created a custom implant, a new dome for this patient that was customized to his anatomy, customized to the fact that he had a fusion underneath it. And that allowed this patient to keep having motion. And he continues to play 18 holes of golf 3 times a week and is very active and functional. So that is a personalization process that happened for this patient who initially had an off-the-shelf option. Here's a patient of mine. This is her motor vehicle, had a crash, lost control of the car, and hit a brick wall. Car's totaled. She was at an outside state. She wasn't a patient of mine at this point. Went to the trauma bay. The trauma surgeons, so her one ankle, the bone had popped out of her ankle, out of her skin, was on the street, and she was in the trauma bay of the hospital. And the trauma surgeons said that you need to get amputated right away. Mom begged the surgeons not to do that. And so she went back to the scene of the accident, found the bone, brought it back to these surgeons. But you know that that bone is too dirty and the infection risk is way, way, way too high. So they did not put the bone back in. She finds this on social media and comes over to see me. Now, again, we're talking about personalization at this point. How does personalized implants help you around the ankle? So this is what this patient comes back looking to me. I know most of you have never looked at x-rays, but this patient's missing the heart of her bone of her ankle called the talus, and then she's also missing the inner bump of your ankle. If you feel that bump on the inside of your ankle, she's missing that as well. Both of these things were lost during the trauma. So what we did is we again used 3D printing, and with that 3D printing, we can create a new bump for the inside part of their ankle. We can also create a 3D printed talus, which is the bone in the center of your ankle. We again, this bone was on the streets. So we used our uninjured side to model and template the injured side. And this is what it looks like. This is about 6 years out, a personalized solution to her anatomy, her needs, that gives her motion. She's not 0 out of 10 pain. She's about 1 or 2. But she's in her mid-20s now and has had this implant and is doing well and functionally is doing very, very well. Here's a patient of ours where has severe ankle arthritis, bone on bone, but also the talus is dying. So it's collapsing and dying, and it's actually shifting from the front of her shin bone. So the whole ankle, the whole foot is moving forward on her shin bone. And so again, we can use a customized solution to provide this patient a personalized implant. The talus, the entire bone can be replaced with an off-the-shelf top. So she's got an ankle replacement on the top, a total talus replacement on the bottom, and this allows this patient to have an option for solutions. Here's a patient of mine in 2020, had an ankle replacement done at an outside hospital. This is what this ankle replacement looks like. Within a year, she starts having pain and she's getting loosening of the implant. This implant is starting to get loose. It's called aseptic loosening. It's not infected. It's just not bonded to the bone. So the original surgeon redid it with what's called a revision. So took it all out, put new implants in. These new implants also started loosening. But now that talar piece is sinking into the bone. So now we're losing the foundation of your ankle. So you got to kind of rebuild that. Now, the bigger question is, why is this all happening? Um, I believe that a lot of patients can have metal allergies to implants. And in fact, there's now a metal allergy blood test that can be done. And we had this patient get tested. And in fact, she was allergic to nickel, which is found in many off-the-shelf total ankle replacements. Um, in fact, about 10% of patients who have orthopedic metal surgery can have a nickel allergy. That doesn't mean that they're all reacting, but they can. And this patient was. And so we created a custom personalized option of a metal implant that had no nickel in it. And she's doing very, very well finally. All right. So this implant is entirely personalized to this patient. Here's a patient of mine that I had done an ankle replacement on. He did very well for about a year. And then after that 1 year, he started having severe amount of pain. And so we took him through a battery of testing to try to understand why on x-ray does this look great, but you're having this kind of pain. So eventually we get to a point where he is allergic. He did not even know he had metal allergies, but he's allergic to multiple metals that he was unaware of. And so although the implant looks great on x-ray, they're having pain, they have a metal allergy, the body is not liking this implant. And so, again, like I told you early in this talk, material science is continuing to evolve. So this patient was able to get the first, it's a medical grade plastic implant of the world. Okay, so this is the options of the implants that we have available to us, customized to this patient, personalized to his anatomy, personalized to the fact that he doesn't need any metal. We put bone behind the implant so that it can really grow into his native bone. So this is me spackling some bone onto the implant. This is what the implant looks like on the left in the operating room. But on the right, you can see there is no metal in that ankle replacement. You just see these blank spaces. And this patient is now almost 2 years out. And you can actually hear from his own words, and I'm going to play it for you, a CBS Philadelphia news story that you can find online and is available. But we have time for me to
A
play
new
this.
high-tech treatment for people who need ankle transplants.
Health reporter Stephanie Stahl joins us now to show us how it works.
That's right. For ankle replacements, this is very interesting technology. This is a new plastic implant that can help some patients heal faster with fewer complications.
That's right.
After years of suffering, Noemio Oliveira has a new high-tech ankle replacement.
A lot better. It's about 300% better. I mean, there's no more swelling, right? It's no pain.
He says his ankle ordeal started with an injury that happened in a car crash.
I had the original surgery in the morning of the accident.
Oliveira eventually had a traditional ankle replacement with a device like this, made of metal. But that caused even more swelling and pain. He and the doctors didn't know he was allergic to metal.
In years past, we didn't really understand why the pain was happening. We thought maybe it was an infection. What is emerging is that many of those patients actually have an undiagnosed metal allergy. And there's technology that is now being created to help. Because it's plastic, you don't see it on X-ray at all.
Dr. Selene Parekh with Rothman Orthopaedics says the new option for people with metal allergies is made of a specialized plastic.
This is the bottom of the joint replacement. This is the top of the joint replacement. And in between would be a white plastic piece that allows the joint to glide.
He says the new plastic ankle implant is hypoallergenic.
It's a huge development for multiple reasons.
Dr. Parekh says the new implant helps with bone growth and limits infections.
Thought it was almost too good to be true.
For Oliveira, he's thrilled to be walking without pain, back to doing the things he loves.
I guess I feel special, right?
Now, doctors say
So again, you can watch that online if you just look up my name and CBS Philadelphia. So who's the ideal candidate for total ankle replacement? You know, when total ankles were first being done, we were very conservative, saying 60-year-olds and above, those who weren't so active, those who didn't have an alignment issue. That is all gone. Those of us who have had a lot of experience doing ankle replacements now do it in 20-year-olds all the way to 70, 80, 90-year-olds. It doesn't matter your level of activity, understanding that once you get this done, we really don't want you running and jumping. We want to make sure you have good quality bone and that we can correct your deformity either in the office or through one surgery to realign you at the time of the ankle replacement, or sometimes it's a staged procedure where you get two surgeries to get the realignment and then the second one to put the ankle replacement in. The future of ankle replacements is really, really bright in my opinion. Like I said, when we first started, a higher failure rate. These implants were not as anatomic. The material science was basic. It was just metals. We are getting better with patient-specific instrumentation, with personalized solutions that can be offered for those patients who have unique issues. There's better bearing surfaces that are coming out. We can use AI now to help with preoperative planning. We can use biologics to help grow the bone and secure the implants. And there's some minimally invasive techniques that are on the horizon using augmented reality and artificial intelligence. So all of this is coming down the pike to help the surgeon, individuals like me, to do this surgery more reliably and hopefully provide better outcomes to the patients. And so with that, I will open the platform to questions for anybody who may have some. All right.
Okay. Hi, I'm back. Okay, so do you see the question and answer box? Do you
I
want to
do.
minimize the screen so we can see your face better?
Absolutely. Hold on. Is that better?
That's better.
All right. So the first question here, and I'll read them so that you understand what I'm responding to. For those of us that do have primary arthritis and not injuries, such as rheumatoid arthritis, how are things different? Um, that's the first part of this. Well, it can be different because your conservative options may be different. If you have an inflammatory issue, perhaps you're on biologics, perhaps you're on medications that the post-traumatic ankle arthritic patient doesn't have a response to or doesn't really need. But at the end stage of your primary arthritis, the treatments are the same. When you get to the surgical options, they are the same, ankle fusion or ankle replacement. So we don't handle those any different, and the challenges for those are not really any different. If you are on some of these biologics, though, typically before you have any type of surgery, whether it's fusion or joint replacement, you will need to have a period of time off the biologic medications, anywhere from 2 to 4 weeks. And then you'll have to be off of them for about another month after your surgery because we know biologics can slow down the wound healing and also lead to higher risk of infection. All right. Next one, Dr. Parekh, for personal TAR. Oops, I just lost that. For older patients, how does my approach differ compare to other TARs? How many have you done? Complications, recovery time, mobility, lifespan. So, okay, so if you get a personalized implant, it all depends on the type of personalization you need, right? If you just need like that talus being replaced, it has its own recovery. If you're getting just the talus and an ankle replacement on top, that has a different recovery. If you need something fused or growing into those implants, that has a different recovery. If you get the plastic ones, that's a different recovery. So it's hard for me to answer all those iterations, but more or less at a very high level, know that you will be non-weight bearing at the low end, 3 weeks, at the high end, 10 weeks. Again, depending on what you really need from that personalization perspective. The lifespan of these implants that are personalized, yeah, we're tracking them. Some of these variable surgeries, like the total talus implants, I have the most of those in the world. We have patients flying in from everywhere for that. And we are tracking these to see how patients do over the course of decades. Our oldest ones out are about a decade out and so far are doing well. And we are routinely, every few years, reviewing that data and publishing it in the peer-reviewed journals. The second part of that question is, how is all of this practical for out of state for transport, recovery, or downtime? Yeah. So we get patients who fly in from all over the world. And the options are, if you wanted, you can do all of your follow-up with us. If not, I oftentimes will tag team with a local orthopedic surgeon of that patients from wherever they're from, and we will tag team with them where the orthopedic surgeons in the local market will do some of the postoperative visits, and I will do the key ones where I really want to make the important assessments. And so we can easily do that and work that out. All right, next question. What if you also have midfoot arthritis? Do you recommend ankle replacement or midfoot fusion first? That is all very specific to potentially what's going on. There are times that we do recommend the ankle replacement gets done first, especially if that's the more problematic area, because that extra motion you're getting may unload your midfoot and allow that midfoot to become less symptomatic. But there are other times that we think the midfoot should be done first because there might be deformities related to it. And if that's more of the driver, you take care of that first and you do the ankle replacement second. So it just really varies depending on what your specific condition and issue is. Recovery time. So for any of the things that I've shown, the recovery time to full recovery, I tell everybody 1 year. We know for up to a year, pain, swelling, motion, function, numbness, tingling, all of that continues to get better for a year. However, having said that, the vast majority of that recovery happens within the first 4 to 6 months. So you will really kind of feel like you're as good as you're going to be at the 4 to 6 month mark, but you still get better for up to a year, if that makes sense. Next question, in the event of a large amount of arthritis in the ankle joint, is that removed at the time of the ankle replacement? Yes, it is. Absolutely. So the way it works is we take bone cuts that get rid of the joint that's arthritic. Those bone cuts make space for us to put in a metal piece, a plastic piece, and a metal piece underneath. So you get three components to your ankle replacement. And when we do that, we get rid of the arthritic joint. So that arthritis is gone. Um, all right. Are patients routinely tested for metal allergies? We do not at this point do that routinely, and there's a reason for that. I will verbally screen every single patient, right? We ask them, do you know of any metal reactions you've had with jewelry in your earrings or nose rings, rings on your hands, watches? And if they say yes to any of that, I recommend metal testing. The reason why we don't do it routinely for everybody is that there's only one lab in the US that does this blood-based metal allergy testing and is not covered by insurance. And so it can run you a few $100s. And so to test everybody for it really is really not really a good way to practice cost-effective medicine. So what we've done is come up with more of the verbal screening. And then if you're positive on the verbal screening, we then ask that you get metal tested. I am working with a group that is looking at a way to offer patients metal testing, at least a screening that can be done for everybody, but we're not ready for that or there yet. Next question. After ankle replacement, what limitations should a patient expect? So the postoperative recovery varies from surgeon to surgeon. For me, if it's just an ankle replacement and we're not doing any bone work, we're not doing any bone cuts, any ligament work, any tendon work, and we're just giving you an ankle replacement. For those patients, they are in a cast, not walking on that ankle for the first 3 weeks. Then at week 3, we flip you into a boot. We let you walk on it. That's for another 3 weeks. And then at the 6-week mark, you're working your way out of the boot and into physical therapy, working on motion, strength, and agility. Most patients need 2 to 3 months of therapy to regain as much motion as they can back. Next question. What happens to the peroneal nerve in the foot if you have an ankle replacement? So typically, the bigger branches, if we see them, we mark them, we move them out of the way. But there are really tiny branches that we can't even see. They inevitably get cut. Whenever you have any type of surgery, we are cutting, every surgeon is cutting through these tiny little nerves that you can't see. Those branches, most of them reestablish themselves over the course of the year, but not all of them do. So anytime you have surgery, there's less than 1% chance of nerve injury, right? And meaning that maybe you end up with some hypersensitivity in some parts, maybe you end up with numbness in some parts. That is unfortunately a risk for any type of surgery. Let's see. What does AI do to help surgeons with ankle replacement? Well, this is evolving, just like AI is evolving in all of our personal lives. Right now, the AI is being deployed for some of these personalized cases, right? So there's enough volume of these personalized cases that have now been done that you can put AI behind it. And when a new case comes in, the AI can start predicting what does this implant, what is it going to look like? What should the solution be? Then an engineer and the surgeon will look at the design that was offered and then finalize it before it is actually printed for a patient. The AI is also starting to do that for the patient-specific guides that are being created. But ultimately, the engineer and the surgeon need to sign off on this to make sure that the final product is what can be utilized properly in the operating room. Next question. Why am I on physical therapy for my knees in a week and much longer before therapy for an ankle? Well, so remember, remember a few things. Your ankles are much smaller. They don't have a soft tissue envelope that the knee has. So that's one issue. Because of that, we have to really be protective of our incisions. We don't want these incisions falling apart or having problems healing before we send it to the therapist and they're really working on motion and stretching things out and really pushing on stuff. So we really don't want any therapy started till the wounds have healed. Additionally, these are small joints, small implants. We are relying on your body to grow into those implants and secure them. Unlike your hip or knee, which have huge surface areas and your body can grow into kind of spot welded, you have a tiny little surface area for the ankle. we have one shot to make that really grow well. So we really want to be conservative before we get you to the therapist where they're really working on motion and strength, and it may potentially slow down the ability for the bone to grow into that implant. Next question was, does Regenix, I'm assuming regenerative medicine treatment work? Yeah, I mean, I do offer regenerative medicine treatment options in the form of stem cells. I don't believe PRP, in my opinion, works for arthritis of the ankle, but for arthritis of the ankle, stem cells seem to be very, very good in the right situation, right? So once you have bone-on-bone arthritis, it's not really an option, in my opinion. But if you have early to mid arthritis, it actually can work very well to decrease pain and inflammation. It doesn't grow new cartilage, but what we're trying to do is decrease the symptoms so that we can increase your quality of life and delay the need for the ultimate ankle replacement. So I have found it to work very well in those scenarios. Next question. Do you advise hardware removal at the same time as a replacement or two different surgeries? That is, it depends on how much hardware, in what location, and what needs to be done at the time of your ankle replacement. So there are times where you can do it all at one setting, but there's other times where there is so much hardware or in different locations that the surgeon will say, you know what, let's take the hardware out. And then after that hardware's out and you've recovered for a period of time, we will bring you back for the next ankle replacement surgery. So it really just depends on what is happening for you individually and what your surgeon wants to do. The next question, are patients that are on Eliquis eligible for this procedure? Yeah, absolutely. Whether you're on Eliquis or warfarin or Lovenox or any of these blood thinners, yes, you are eligible. However, your cardiologist or your primary care or whoever is giving you the blood thinner has to medically clear you, has to come up with a protocol of taking you off those medications for a period of time before your ankle replacement. And then typically the night after your ankle replacement, you restart these blood thinners. So it can be done, but it needs coordination between your surgeon and your primary care or the cardiologist or whoever's giving it to you to come up with the protocol for you. All right, I have a patient. This is a question. It's a patient of mine. Had their total talus with a total ankle 7 years ago, having a very active with near full range of motion, a little arthritic pain in the shoes. Only downside, I've set off the metal detector in the airport a few times. Well, yeah, unfortunately, we can no longer give patients cards for implants. Prior to 9/11, we could, but after 9/11 and you know the novelty of the internet, those things can be falsely documented and obtained. So that's no longer unfortunately available. But I'm glad you're doing well. Next patient or next question. I had PRP for a torn peroneal tendon. What procedures would need to be done to address tendon damage? So just because you have a torn tendon doesn't always mean that you need to have surgery for it, especially in the setting of an ankle replacement. If there is some weakness or some issues that could affect your ankle replacement or that are symptomatic for you, then yes, that could be done. And for torn tendons, we can either repair them, reinforce them, or replace them. It all just varies on the tendon and the specific issues that are going on. So it would have to be something that's assessed by your surgeon, and a discussion should be ensued, and then options should be discussed. Next question. I used a bone regenerator for triple arthrodesis surgery. Can I use it with TAR? Yeah, that's a great question. I'm a believer of bone stimulators as well, for patients, especially when they're struggling to heal. There has not been any studies looking at bone stimulators for total ankle replacements, primarily because that is not something that is covered by insurance. And so the most bone stimulators are $4,000 to $5,000 or more. And until, you know, those would be routinely covered, those studies wouldn't be done. My worry about a bone stimulator with an ankle replacement is that you have a metal object that the bone's trying to grow in. All the success rates with bone stimulators is where bone is trying to grow into bone, not bone into metal. So I don't know if the metal changes the behavior of that bone stimulator. and its efficacy. So in my opinion, I wouldn't do it right now because I don't have any data to suggest it would be very helpful. And in fact, I can make the argument that it might be harmful. All right, next question. Can you dance, do yoga, wear heels after you've healed? Again, something that should be discussed with your individual surgeon, but from my practice, you can dance, you can do yoga, you can wear heels, limited. I don't want you wearing stilettos and I don't want you wearing 3-inch heels or something that's really skinny on the bottom. Chunkier stuff or things more of a platform, I'm totally fine with. I really want patients to be under 2 inches because I just worry about loading the implant in a really odd way. Again, there's no data on this. It's just something that I think's best practices. But having said that, listen, if it's the holidays and you're dressing up, go have fun, do it. Next question. Will continuing to use the arthritic ankle with pain meds make the inevitable ankle replacement more difficult or risky? That is really individualized as well because it also depends on kind of what's happening in and around the ankle arthritis. But at a very high level and a very generic answer, it should not make, for most people, it doesn't really make a difference. The ankle replacement surgery that's done tomorrow is the same as that will be done 3 years from now. The implants may change, the materials may change, but the approach is typically the same. And it's not any more difficult unless you have a patient who's got an alignment issue where things are off. That can get worse over time. Or you have bone loss. That gets worse and worse and worse over time. So again, a little bit of the answer to your question is really specific to what your surgeon sees on x-rays. Next question. I had my shoulder replacement in August by one of the Rothman docs who did a great job, including 2 knees. Do I need to wait for an ankle replacement? Yeah, so for my patients who have a hip or knee or shoulder replacement, as soon as their primary surgeon who did that procedure gives them the go, I'm ready to go with an ankle replacement. There's no need to wait once you get the green light. But I don't proceed unless I get the green light from that surgeon because they know that implant and what they did best for that joint. And I want them to say they're okay with whatever extra stress that's going to occur. Because remember, with an ankle replacement, you are non-weight bearing for a period of time. So that means you do put extra stress on knees and hips and shoulders because you're using crutches or a walker. So we want to make sure that your surgeon signs off on those things before you get your ankle replacement. Next question. What is the potential damage if you sprain the ankle after a replacement? Yeah, that's a great question. I tell patients that, listen, you get a joint replacement for sure, but can you damage the joint if you twist it or you injure it or you fall? Yeah, you could, just like you could damage your native ankle. So can you tear a ligament? Can you tear a tendon? Sure. Can you break a bone? Absolutely. Interestingly, though, we don't see as many torn tendons or ligaments after a joint replacement. You can see broken bones, but it's extremely rare to see a ligament that's torn or a tendon that tears. And we're not really sure why. All right.
Hey, that
Any other
looks like
questions?
it. That was so interesting. Thank you so much. You always do the best presentations.
No, my pleasure. Always fun
Uh,
to do.
And so, if anybody is interested in speaking further with Dr. Parekh, would like to schedule an appointment, like I said, you have my email and my telephone number. Please reach out to me and we will get you scheduled. This was recorded, so you will get an email. It's usually within a week, and you'll get an email with the link so you can revisit and all the whole presentation as well as the questions. So, again, thank you so much, Dr. Parekh. And thank you, everybody, for sharing your evening with us. And we really appreciate you.
Yeah, thanks, everybody. Pleasure meeting you.
Alrighty, take care. Bye-bye.
Yeah, bye-bye.